Welcome everyone to this patient-focused webinar. I'm Shalene McHale from Insight Tech, and I'm pleased to be a part of today's virtual education event. Please be patient as we take a few minutes to allow everyone to get signed on. The presentation will begin shortly. Good evening and welcome everyone. Again, this is Shalene McHale with Insight Tech. I'm pleased to be a part of today's virtual education event, and we're going to get started in just a few minutes. I'm just giving everyone the opportunity to get signed on. Great. Looks like we have a great number of attendees signed on, so let's go ahead and begin. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. Pulik Ray as he discusses MR-guided focused ultrasound as a treatment option for patients diagnosed with essential tremor or Parkinson's disease. As questions arise during the presentation, please go ahead and utilize that Q&A button. You'll find it at the bottom of your screen. We will have time after the presentation to answer the questions that are asked within that chat. And I'm just going to remind everyone to go ahead and do that as the questions arise during the presentation so you don't forget what your question is. Let me begin by introducing you to today's presenter, Dr. Pulik Ray. Dr. Ray is the medical director for focused ultrasound at Christiana Care and a partner of the Delaware Neurosurgical Group. Dr. Pulik Ray is an MD, is a board certified neurosurgeon who specializes in surgical management of brain and spinal disorders. He specializes in the area of neuro-oncology, minimally invasive spinal surgery, adult deformity surgery, complex spine surgery, neuromodulation, which includes spinal cord stimulators, neurotrauma, and cerebral vascular neurosurgery, as well as MR guided focus ultrasound. He is actively involved in collaborating research programs as well as clinical trials at the Helen Graham Cancer Center, Christiana Care Health System, and the University of Delaware. Dr. Ray is an adjunct faculty at Worcester Cancer Institute in Philadelphia. In this role, he directs the HGCC Brain Tumor Bank and assists in steering translational research in brain tumors as well as cancer metastasis. He actively is published in peer-reviewed journals and is in relation to cancer research in many different areas. Dr. Ray was born and raised in Maryland and attended the University of Maryland at College Park for his Bachelor's of Science. He then went to the University of Maryland at Baltimore for his medical school. After research fellowship, where he studied neuronal plasticity at the National Institute of Health in Bethesda, Maryland, he then proceeded to Temple University Hospital for his neurological surgery residency. Needless to say, Dr. Ray's got a very well established resume. Dr. Ray mostly enjoys time with his family, exercising, and fishing. And so we're super thankful that he has time to join us this evening. Thank you, Dr. Ray, for being here. The floor is all yours.
Thank you so much, Shalene, for that introduction. I'm so excited to be with you guys again today, talking about focused ultrasound. Um, as you can imagine, as you can see, neurosurgery is a field where we treat multiple different kinds of conditions and the breadth of conditions associated. One of the big things that we treat and we see a lot of is patients who come in with us with difficulty with balance, difficulty with movement of their arms or legs, and it's a lot of it's on us on us and the neurology teams as well as the primary teams to determine what's the cause of these problems. What is it that's really at play? So a patient will often be seen by us for a spinal disorder, and when we look at them further, they'll have instead of it being the cervical spinal issue, it'll in fact be Parkinson's or essential tremor or something. So in order for us to fully treat a patient, we really should step back, understand the entirety of the condition, and then work as a team to see how we best treat people. So with that, I want to discuss focused ultrasound further, which is really a life-changing treatment for patients with essential tremor and tremor-dominant Parkinson's disease. I have no active disclosures. So in today's agenda, we're going to talk about the essential tremor, facts of um, essential tremor impact, treatment options, what's the fuss with fuss, who is suitable for the treatment, what happens on treatment day, what should you expect on that day as well as the days to follow. What type of outcomes are we seeing? Do we have long-term outcomes? What are they? What centers are present, and how is the insurance coverage? And then we're happy to answer questions thereafter. So essential tremor is also referred to as a familiar or idiopathic benign tremor. It's essential means that no one really knows the medical cause of it. And it occurs in up to 50% of cases that's in fact hereditary in nature, so it's passed on. It can progress to the point where daily living is difficult to perform activities such as lifting a spoon, drinking a cup of water, trouble with your handwriting, trouble holding onto objects, trouble maintaining independence, which is such an important aspect of a person's life. The impact is it affects about 10 million Americans. Patients often live with this debilitating condition and do not seek treatment. And even those who do seek treatment, they have difficulty responding to the medication. So 50% of people do not have satisfactory response for medications or see significant side effects. First-line medications include propranolol or Inderal, primidone. Second line includes topiramate. Third line, we try gabapentin, benzodiazepine, botulinum. But unfortunately, again, 50% response rate is not optimal. Our treatments have been, from a surgical standpoint, deep brain stimulation, which is an effective and has often been considered the standard of care for these conditions in the past, and requires a stimulator in place and working. Focused ultrasound, which is what we're going to discuss today, radiofrequency thalamotomy, stereotactic radiosurgery, so radiation dose to similar locations. And we'll talk about why there's benefits of doing focused ultrasound compared to radiosurgery. There are devices that try to improve on tremors, such as Calitrio as well. So what's the fuss with fuss? So fuss is a focused ultrasound, is a MRI-guided focused ultrasound. It is indicated in essential tremor and tremor-predominant Parkinson's disease. We use a greater than 1,000 high-intensity sound waves that are directed in a helmet to a specific location with no incisions. We're able to use those sound waves and meet them in a specific location about the size of a pea, so less than a centimeter in size, and apply heat without disrupting any other structures in the surrounding areas. The main target that we look at is VIM of the thalamus, and is the same as that used in deep brain stimulation or surgical thalamotomy. Many patients experience immediate tremor improvement with minimal complications, and that's really one of the most exciting aspects of this. Is that let's say we have a first start with a patient at 8 a.m. By 10:30 they're often walking out having a significant resolution of the tremor that has been causing significant difficulty in their life. This is an example of what we sometimes see. This is Archimedean spiral, and when the patient first tries to draw this before treatment, we can see how much difficulty they have remaining within the lines. And after the treatment, and often in the treatment, we see the significant improvement of how the lines, how you can stay within the lines, and that is a sign that we are making progress.
The essential tremor for me has really put a damper on my life. If there's anything I can do on my part, I should do it. I Googled focused ultrasound. If this can help my tremor, by all means, I will do it. I will do it. There's no cutting, there's no stitches. I will be able to live doing the things that I once loved and can do again. Look at it.
Look, it's like that.
Look at that.
It's amazing, right?
I don't believe it. Oh,
Let's take you to see your husband.
Hi, honey.
You shake it?
No.
That's wonderful.
The
So it's been about 20 years first for Focus Ultrasound. The company was first founded in 1999. Since then, the first treatment was performed in 2005. FDA approval was obtained for a first site essential tremor in 2016. In 2018, Medicare started to cover this, and FDA started to look into approval for what we call tremor dominant Parkinson's disease. And we've continued to add locations that we could approve the treatment for in new targets. In addition, it is now approved for second site as well. So if we're treating, let's say someone has a right-handed tremor and they're right-handed, we're going to treat that left brain first. And then once that has a good response, and about 9 months later, we're able to treat the other side, which is a game changer. So worldwide, in terms of procedures, you can see how there's been a significant improvement, increase in treatments overall for essential tremor and Parkinson's disease. In regards to specifically for the treatment of essential tremor, in the past, deep brain stimulation was the main method of treatment, and as such, you can see in 2018 how there were about 1,500 procedures being done, and that really hasn't changed over time. But what we have seen is that once focused ultrasound was added, there was a pretty exponential incline in the amount of procedures being done. And what's interesting here really is that as deep brain stimulation has remained stable, what we're seeing is that with the identification that people understand that this is a non-invasive treatment, less invasive treatment option, they are willing to undergo this procedure because it is safer for those who are a little more frail in nature. So it's really exciting to see that we are able to treat more of our population now that we have this technology. So who's suitable for treatment? We utilize it for patients who have confirmed diagnosis of medication refractory essential tremor or tremor dominant Parkinson's disease. You have to be 22 years or older for essential tremor, 30 years or older for tremor dominant Parkinson's disease. They have to be able to tolerate the procedure without some form of sedation. We have to be able to communicate directly in terms of what's going on, in terms of how you're feeling. You have to be able to fit inside the MRI. There's a button called the stop sonication button. So while you're in the machine, if things become too uncomfortable, there is an opportunity for you to hit that button and have us stop the machine and come and check on you. The contraindications are that the standard contraindications for MRI, such as non-MRI compatible implants, pacers, and things like that. We get a CAT scan after we identify that we have a person who needs treatment and see if the density of their skull allows for us to do this procedure. A skull that has too low density and has the sound waves will actually bounce off, whereas a skull that's too dense, the transmission through the skull is often too efficient. So we really have to work in that balance to make sure that we can treat people. Fortunately, most people are within that window that we can treat them. So how does this work? So this has been 20 years in the making. It's a closed-loop system with real-time imaging, which means that once we have you in the machine, we're able to use a high-level technology with MRI as well as what we call thermography to identify how to best treat locations of the brain. We can steer the acoustic energy through the helmet, and we can do and it's a non-ionizing radiation. So it's really sound waves. It's not normal radio waves. So this is an example of an MRI where this table comes on, and that's the helmet that you're looking at. Once we secure the head in the head frame and they put it in the helmet, we then do a test MRI to identify the locations in the brain that we can target specifically to what we call VIM thalamus. Once we've identified that location, we can then apply the acoustic energy and apply an initial stunning dose to control to see whether people are going to respond. We then are able to test in the machine to see if the handwriting for the patient improves, to see whether they're able to drink from a cup of water or mimic drinking from a cup of water, and make sure they have no side effects related to numbness or any other significant problems. Once we're comfortable that we've effectively stunned the cells with a low dose of this sound, a sound wave, we can then apply a higher dose to cause what we call the final sonication. And so that's where we get the definitive treatment.
During the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects. During the treatment,
So let's review what happens on procedure day. So first is patient prep. The night before, we ask that you shave the entirety of your head and try to get it as smooth as possible. In the morning of, we're going to check again to make sure that the head is shaved. Strangely enough, the hair follicles actually cause a significant redirection of the sound waves, and we have to make sure that that is like really dialed in terms of how we shave the head. Afterwards, we take a look at the frame, see how it's going to sit to the head. We then apply a numbing medicine or lidocaine to the skin, so that when we apply the pins, we are able to do it under as much comfort as possible. We usually then inject a little bit more numbing medicine around the pin so that you're comfortable throughout the entirety of the procedure. Once it's secure and we're satisfied that it's symmetric on the head, we then take you to the to preparation, where we apply, put you in the machine, and start the planning. In the initial MRI, again, you're awake through the entirety of the procedure, and you're able to lie on the MRI table, and we're going to get an MRI of you in the machine so that we can truly identify real-time the exact location that we want to treat. Once we're satisfied with that, we're going to do a low dose of energy to accurately pinpoint the location and provide a temporary relief of the tremor. Again, once we've identified that location, we apply the high energy to create the small area of ablation in the brain and provide a permanent therapeutic effect. This has significant benefits to patients. We have immediate and durable tremor improvement. So again, I've seen patients who come in at 8 o'clock with a life-disabling tremor, whose biggest complaint was that they couldn't drink a cup of coffee for the past many years, and immediately after the treatment, we're able to hand them a cup of coffee and take a drink. Again, we cannot guarantee that all of the tremors are gone, but a significant improvement that allows you to live happily with your quality of life is the goal. Outpatient, so you go home the same day for this treatment. There's little to no risk of infection. There's no implants, probes, or ionizing radiation, no anesthesia, and overall very, very low risk of complications.
Hi, my name is Jody Meyer. I'm from Greenville, Wisconsin, and I've had an essential tremor for 18 years. I am an office manager for 891 Center, where I partake in a lot of meetings. The tremors in my hands becomes very difficult to speak in front of the groups in the committees. Being a mother of 3 children, the essential tremor is becoming very, very difficult as far as preparing meals for my children, putting on my daughter's makeup for her cheer competitions, pouring them a glass of milk. I struggle with that every day on how I can try to hide from people not seeing me shake as much as I do today. I would love to cuddle with my children when I'm holding them close and not thinking, are they uncomfortable because of the shaking when we're cuddling? In July of 2016, I seen that the Focus Ultrasound was approved by the FDA. For 18 years, I've been praying for some kind of relief, and it's going to finally become true. This essential tremor is not going to rob my life anymore. When they put the clipboard up and tested how I was able to write, I got overwhelmed with emotions because I haven't been able to write for 18 years. Being a mother of my 3 children, after the procedure, I've been able to pick up a lot more daily tasks that before I used to rely on my children to do. Simple things such as tying their shoes. My family was very excited. I'm able to do a lot more things, more independent, to be a stronger mother, to be a stronger person. I'm able to stay up to speed to make sure that all of my daily tasks are completed. I have more confidence where I'm able to join the group and have conversations.
So just some examples of what we see. You know, this is an example of a person who, people who have had treatments, and you can see the before and after here, and just like how impressive it can be in terms of the response for this treatment. This is what an MRI looks like after. So this is what we call the thalamus here, and you can see this small area about half centimeter on the inside part here with a small rim around it. And after the treatment, this area will pretty much hollow out and then shrink down, and that provides what we call the ablation, or the part of the brain that we have in fact affected to stop the tremor. So what are our 5-year clinical results? The reality is that this does show durable response. At 5 years, we see 73% tremor, significant improvement. Patients are telling us that they get tremor relief. The psychosocial benefit is significant. The physical perception is really important. They have an improvement of return to work in their financial position. They have enjoyment from hobbies and leisure. After treatment, the most common adverse effects that we see include imbalance, numbness, and headache. It's not uncommon to see develop some balanced problems afterwards. We do often say that, look, if you may want to have a walker or something at home after available to you, just in case you have balance problems. But usually within 2 weeks, that's going to resolve or improve significantly. The numbness and tingling is another one where we have conversations that says, look, as we see that area of the brain kind of shrink down and improve on the MRI, you're going to have improvement. But there are some patients who will have a longer-term effect. About 8% of people will have continued imbalance, and 3% of people will have unsteadiness, and then 3% will have a gait disturbance. So, you know, this is a real procedure. It does burn part of the brain tissue in that location. So it does cause a legitimate change to the brain. It is not something we take lightly. It is something we have to really be focused as to what are we treating here, how do we treat effectively, how do we give people safe outcomes so that they're satisfied that this really improved their quality of life. How do we avoid adverse events? So ultimately, we are able to provide that low-dose treatment first and help us understand what changes we're causing. Did we improve the tremor? Did we, when we test that using the spiral as well as the glass holding the bottle of water, we can ask patients about whether they're getting any numbness or tingling, and then there is a lot that goes on from a computer modeling standpoint that allows us to identify that we are treating where we want to treat and not treating what we don't. So it's really important that we pay a lot of attention to that circumstance. So what about the other side? So what has been ultimately approved is that the FDA has approved for treatment on the other side at about 9 months. Who is suitable for second side treatment? Essential tremor patients with medically refractory tremor should be staged at least 9 months after the initial treatment. They have to be at least 22 years old, and VIM is the only approved target at this time for that. This does have nationwide coverage. It is approved in all states by Medicare, and most Blue Cross plans, and really most plans in general, have approval for this procedure. It is the direction that a lot of movement disorder treatment is going to go. It's just a matter of understanding who responds well to this, who responds well to normal deep brain stimulation, and then trying to talk to each person and personalize what is right for them. There are certain patients who have significant benefit, especially Parkinson's patients with deep brain stimulation, and for those patients, that should be the treatment of choice. However, they can also be considered a low-risk procedure, but it does require an electrode go into the brain, and there's risks bleeding associated with that or infection, but it's very low overall. And so compared to that, to focused ultrasound where you're not doing those invasive things, but you're providing that permanent response, but you don't have the ability to do what we call modulate. So there's less chance of opportunity to program the coverage compared to that of an ablation. So there are differences, and there's benefits to each, and that's a very personal conversation that you'll have with your surgeon in regards to this. So the first case was, this is an example of the first case.
Just start with your left hand, touch your nose. Push my finger, go back and forth. Other hand.
So it's been, I think, almost 2 years now since we started this, and doing this first treatment again.
That really brings it out, right? All right, relax.
Brushing my teeth without the, having been off the drugs, the medications for a while.
That's tough.
So
Yeah, yeah. I assume probably also drinking or bringing in
Well,
coffee.
I have water splashing.
Yeah. So we're just gonna do your right hand, okay? And remember, without resting your wrist down, so keeping it up. Just draw a line from the center, kind of going all the way out that way. Okay. Can you do the smaller smile?
Right.
I know. We want it messy, right? So we can show the improvement. And then just connect the dots, that dot to that dot right there.
Getting started is the hard part.
Exactly, yeah, yeah. Okay, and then move this rubber band a little bit. In that space right there, can you write "Today is sunny in Delaware"?
Yeah. Oh, baby.
So that's an example of the patient prior to treatment. That was Dr. Martello, Dr. Martello and I started this program together several years ago, and then started our first treatments, I think, about 1.5 years or 2 years ago at this point. So we're greatly appreciative to Dr. Martello for helping us in starting this program.
Didn't you give him water to start with?
He said he wanted to drink a cup of coffee.
You're right.
No, I didn't have one this morning. Now you got one and you're doing it
Look at
yourself.
that. Whoa, check that out. There's your hack.
Perfect.
So you can see that within 2 hours, the severity of his tremor and how much it improved, and just kind of seeing what a post-treatment patient looks like, and the lack of post-treatment recovery that is necessary is really life-changing for somebody, and allows for a much smoother recovery. So thank you again for listening in regards to this. Our team consists of I act as the medical director and a treating surgeon in regards to this. Dr. Epley and Dr. Maida are going to be my partners in the treatment of this as well. And we greatly appreciate the direct management from the neurology team, Dr. Summers and Dr. Kearns, for in these conditions. The reality is as we all know, most tremors and most movement disorders are treated from a medical standpoint. So it's only when people become refractory or have significant side effects do we really have to move toward these other treatment options. However, that partnership with the neurologist is absolutely essential in the treatment of these patients. Thank
I
you
was
so
just
much.
gonna, Dr. Ray, I was just gonna say,
Mhm.
um, because I have a couple things that I wanted to bring up or talk about, but you started to touch on it. And I think one of the things that makes maybe your program a little bit unique and different is those relationships that you have, right? You
Mhm.
just told a story to us when we got on today about a patient and how you were able to like literally just call up the neurologist and talk to them and send them over. And so I guess from a patient's perspective that's listening right now, can you just talk a little bit more about that like whole comprehensive approach that you guys have at Christiana Care? Because I think that makes a big difference.
Sure. So yes, thank you for bringing that up. Our approach to dealing with this is really the focus on the community. We are all, and I mean all of us, be it the primary care physician, be it the neurosurgeon, the neurologist, seeing multitudes of patients a week. And as we the nice thing about our community is in general we're a smaller community and we actually know each other pretty well. So we're very comfortable with reaching out to each other and saying, hey, this is going on with this patient. Do you mind getting him in a little earlier? Or hey, I just identified a perfect candidate for focused ultrasound. Do you mind taking a look at them, making sure we're not missing anything, and then we go from there. And by doing that, we really have tried to optimize how we communicate, not always electronically, this, that, or the other, but really personally. Because at the end of the day, medicine's we're treating people, and that's got to be the focus. Is that how do we get people back to their lives, back to maintaining independence, back to playing with their grandkids without being afraid of dropping something on them. Yeah, that's got to be the focus, and just keeping the focus on that, I think, is the most essential part of this. And I'm very grateful to our neurologists and neuroscience department that there really has been a maintained focus on that.
Awesome. Perfect. That was what I wanted to hear. Awesome.
Mhm.
I have one more question. You were talking about the second side treatment, and you
Mhm.
mentioned that it's staged and that there has to be a 9 month window between first side and second side. Can you just explain to those that are on and listening right now why? Why can't you just take care of both sides at the same time?
Sure. So when we first meet, we're going to have a conversation that says, what is it that's bothering you? And most people's main complaint is like, I can't do this, I can't do that, I can't drink a cup of water, um, I can't knit, things like that are really affecting their ability to take care of themselves, do the hobbies they enjoy, etc. Essential tremor is often a bilateral issue, so it means that it affects the left and the right side. You want to treat the side that's most symptomatic and most debilitating to someone. So if they're right-handed and the tremor is in their right hand, that means they're not going to be able to write well, they're not going to be able to hold onto their fork and knife, things like that. And even if your tremor is on the left side, we really should focus on getting that back. Why not treat both at the same side? Because the reality is everything we need to do has side effects, and they can be temporary in nature, but if we affect both sides of the brain at the same time, we have a problem. So ultimately, by allowing us to perform an ablation, and I do mean an ablation, we are ultimately burning a part of the tissue to get this treatment option. We want to give the brain a chance to heal, recover from some of the effects of maybe the balance problem or whatever, and then provide the definitive treatment. So what they learned over time is that if you give a person appropriate amount of time, which is, what we found is about 9 months, then people will do better. And that's a great question, and it's the safest way to deal with things. Is
And
that
then,
is
oh,
that probably like a median range? Yes, but that's a conversation we can have together. And again, this is an evolving field. Maybe that changes down the line. Maybe it doesn't. We're here to keep people better. That's the ultimate goal, and we'll do what's safest for each time.
perfect. It kind of piggybacks on that, the next question that's coming up, and it said if a patient already has balance or gait problems, will this procedure worsen those symptoms?
That's an amazing question. We when if you already have balance or gait problems, we need to find out why. Okay, so we find patients who have essential tremor, but also have spinal stenosis, right? So the balance problem was related to the spinal stenosis. The essential tremor was something we could treat with this, right? So two different conditions. Number two, and that's the importance of the holistic approach, is that we really have to look at every person's entirety of conditions and then determine what's right for them. Um, we've also seen patients who the FDA approved and treatment for this has been on towards treatment of upper extremity tremors. We have patients who actually have tremors associated with their lower extremities, and the question is, do they respond? I have had patients whose family came back to me and said the day after that they were off of a walker for the first time in a long time. So anecdotal, it means that that's just one story, but it is something we've seen. But we also have to be cautious that those patients who are kind of teetering on losing their balance, having worsening balance issues, or are already on a walker and are really unstable, is this the right treatment option for them? That's always a difficult question, a very personal question. And then the question is that, well, what's more important to you, getting back your right arm, or risk of requiring significant therapy and potentially a wheelchair if you don't respond. So that's a very personal question that we would discuss.
Right. And then someone was asking in regards to, and you again, you kind of touched on it a little bit. Their tremor is mostly like around their mouth and lip area. And they have left hand. They do a lot of like public speaking and things like that. And they're looking for that tremor in their mouth and lip to go away.
Mhm.
Would
The
this
focus would
procedure
be
help?
on the upper extremity improvement. As I think on that one video of the young lady who had the essential tremor, I do feel like you could hear her phonation improve after treatment. So again, it's such a personalized question, in that we have to really sit together and say, okay, what are the ramifications if this does or doesn't improve? Will you be happy with the fact that you had treatment or not? The focus has to be on the extremity improvement, especially because that's really what we're watching clinically when we're doing the treatment. So when we stun those brain cells, we can examine how that arm does, but it's very hard to examine how your voice does in a machine like that.
Great
So
answer.
it's a great question. Maybe we'll be there at some point. Right now, the focus is on the upper extremities.
And I have two questions in here right now, which I'm not surprised. Asking about the shaving of the head. And if
Mhm.
you're only doing one side, why do you have to shave the whole head? And
Mhm.
is there another way of doing it?
Great question. Sorry, the hair's got to go. And the reason why is that even if you're treating one side of the brain, the way the engineering is done is that the helmet and the machine itself is sending equal waves from all aspects of the helmet, except for the areas that we specifically block off using computer technology. So, in a circumstance like this, where we need such highly accurate treatment and precise, so we need to hit our target and not have any variation on the target, um, we really don't have room for error for even the hair follicles to bounce sound waves in locations that we don't want it to go.
Great. And I'm just going to let everyone know that's on still. If you haven't written anything down about how to get a hold of Dr. Ray and his team, Michelle is still up on the screen. So if you haven't written it down or you're having trouble writing it, if you just want to take a picture with your phone, sometimes that's a really easy way to just capture it for yourself and your family. And then we have one question left that I'm going to ask. And if you do have a question that you haven't put in yet, I highly recommend you do it quickly. The last question they are asking about is where exactly is this procedure done?
Yes. So we do it at Christiana Care Newark campus, which is in Newark, Delaware. It's done at the main hospital. It's done in the MRI suite. So the way we have it set up is that you come to the MRI suite. We apply the frame in the suite. We apply then there's a kind of a rubber boot that goes over the top of the frame. We take you back to the MRI machine. We then are able to treat you there, and you're discharged same day from there. So different parts of the question. It's at Christiana Care Hospital in Newark, and then it's done in the MRI suite.
Perfect. Well, I don't think, oh, wait a minute. Oh, somebody just said, I came late. Um, what is the difference? Oh, this isn't a good question, and we didn't have it asked yet. So they're asking, what is the difference between essential tremor and focused Parkinson's?
Sure. So, essential tremor versus Parkinson's disease, I think, is the question. It's a very good question. You're absolutely correct. Step one is having the appropriate diagnosis. So the difference is that essential tremor often we see happen in both extremities. So you'll see it in both hands first. With Parkinson's, you'll more see on one side. In addition, there's a very specific shuffling gait associated with Parkinson's. Essential tremor you see more hereditary, so more the family members have had it in the past, and maybe it's getting worse through the generations or not. So the difference, if you two easy ways to pick it up is essential tremor you're usually seeing on both sides. In Parkinson's you see on one side. Balance, you see the shuffling gait for Parkinson's. The face changes a little bit on Parkinson's. Those are the most useful things, I think. And then the specific type of tremor is much what we call a pill rolling tremor in Parkinson's. Whereas for essential tremor, it's more so what we call an attentional tremor, which means that as you're trying to do activities, that's where the tremor actually gets worse, not better.
Great. They were also asking about is the secondhand treatment also for the focus treatment or just essential?
Second side treatment, I think is
Yeah,
what they're saying.
I
So
think it's just
essential,
because,
so that's a great question. For essential tremor, we absolutely can do both side treatment. Parkinson's, I think they just got the FDA approval for doing both sides. Is that correct, Shalene?
Mhm.
Yeah. So the reality is, yes, we're treating both sides. It's just that again, we're talking about technology that is cutting edge, and every year we're finding advancements as to how we can treat people, and it's just really exciting.
Yeah, and just for everybody that for the one person that joined late and anyone else that wants it, we did record this evening and this will be sent over to Dr. Ray's team at Christiana Care. So if you reach out, they should be able to get you the recording. If you wanted to re-listen to it or see it or you missed a section of it, and we're happy to get that sent over. It'll probably take a day or two to get it over to them, but it will get over there and you will be able to get a copy of that or ask them to send you the link to it. So no worries there. And then Dr. Ray will be doing more of these throughout 2026. If you want to have a family member or something like that join on for a live one, we're looking at doing 3 more of these this year. So just keep your eye open. And with that, Dr. Ray, I just want to thank you again for your time. And if you would like to go ahead and close out this evening, we should be good to go.
All right. Thank you so much for having me. I greatly appreciate this opportunity. We are very excited about getting people treated and identified. Again, when you're seeing us, please understand that we're here to evaluate you fully and treat you likewise. So just bear with us as we understand what's right for you. We hope that we can move things through efficiently for you, and we hope that we really get you the best experience for this difficult problem that we can. Thanks again.
Thank you so much. Everyone have a great and safe evening. Bye.